This conference will now be recorded.
Okay, can we see a radiograph, one hopes?
Yep.
Okay, this person has elevation of the right hemidiaphragm. I don't have a lateral view to show you that it doesn't go all the way posteriorly. So chances are, given that it dives medially here, back down toward normal height, that the posterior muscle is intact, and this is not paralysis, it's probably eventration. So it looks like a big eventration. And I'll show you some CT findings in this case. Here is a coronal CT, and there's a lot of abdominal fat. And then we have this rather abrupt transition here. We go from unelevated to suddenly elevated hemidiaphragm. This is very good for eventration as opposed to paralysis, which would be a gentle taper back toward the midline. So abrupt transition is very good for eventration. That, once again, that's because the muscle is intact posteriorly. Now, if we go anteriorly, we see that we have good muscle thickness here anteriorly on both sides. And then we have the normal thinning over the dome. So this is an eventration. And there's a lot of abdominal fat which promotes eventration. And there's also something else that is promoting, in this case, this retroperitoneal liposarcoma, presumed at this point. I think it's not yet been biopsied. Sure looks like a liposarc. So that is also selectively pushing up on this right hemidiaphragm and promoting eventration. So here it is, posteriorly pushing up the liver. Once again, with eventration, anterior muscle thickness is normal and posterior muscle thickness is normal. And so we get this steep dive here of the posterior aspect of the elevated hemidiaphragm with eventration. We don't have this dive with paralysis. It would float all the way back to the chest wall. Okay, so this case put eventration made even larger by retroperitoneal tumor, probably liposarc. Okay, continuing on a theme, this person had a little bit of elevation of the right hemidiaphragm back several years ago. I think this is 2020. This would be, sorry, it's 2022, even more recent. And on lateral view, there's just a little bit of anterior bulge, normal height posteriorly, so maybe a small eventration of the right hemidiaphragm. So things are a little more dramatic currently. So this is a recent.
David, we lost your screen.
You did. Okay.
Yeah. Try resharing.
Okay. So let's see. How do I do that?
At the bottom, there's a little share button.
Okay. So it doesn't seem to let me change.
So I'll take control back, and then I will give it back to you and see if that works.
Okay. You know what it doesn't like is okay. Did you see the normal chest radiograph to begin with?
Now I see a radiograph. Yeah, I see a radiograph now.
Okay.
I see a lateral. Yeah, and
Okay.
there's the PA.
Okay, but you don't see the one next to it. It doesn't like the split
No, it
screen.
only shows one port, I think.
That's disappointing. Okay, so that was then, and do you see a different chest radiograph now?
Yes, the diaphragm is up.
Okay. Okay, the hemidiaphragm is up, and on lateral view, you can see that it dives posteriorly. So it looks like a big eventration again. So this person has enlarged an eventration. It was small in 2022, and it's big now. Notice that the abdomen is protuberant down here, and there is a reason for all of this. This person has liver failure, has a knobby-looking liver, a big spleen, and has massive ascites. So this eventration has been enlarged by eventration. Once again, you know, there's an abrupt transition to the eventраted part, pretty normal height, the same as on the other side medially, and that's because this posterior muscle is intact back here, keeping it keeping it down. Anteriorly, we have normal muscle thickness on both sides, but we have this upward bulge. So big eventration caused by this liver failure, portal hypertension, and massive ascites. So ascites can stretch and eventration make it big in a hurry. So that and abdominal fat are the usual causes of a rapidly enlarging eventration. Okay, now let's see if it will accept a transition to another case. Yes, another case or not?
No.
Okay. Jeff, can you enable me to reshare?
Okay, let's see. That's so weird.
I can do it here. Let me do it. Let me do this.
There we go.
Okay. Okay, so this person had a defibrillator placed. I think this is 2022, about a year ago, and then came in this week. And now we notice that the pulse generator has flipped. It's a mirror image now of what it was before, and there's all of this coiling here of the wire. So this is a case of Twiddler syndrome. And I was trying to see if the cable course had shortened through the heart, but it's about the same. So this hasn't shortened particularly, but I've seen people wind these things right out of the heart and cause the electrode to pop back into, say, brachiocephalic vein if there's a lot of coiling of the wire here. So Twiddler syndrome here with coiling.
David, do you know approximately how long after implantation that occurred?
We don't have very many radiographs for the interval, so it's 2022 to 2023 as much as I've seen here.
Okay,
You're thinking it might have occurred early before the pocket sort of scarred down?
exactly.
Yeah, that's a good point. I don't know. Okay, Jeff.
All right, thanks, David. Seth, are you ready yet? I will take, okay, then I'll go and then we can let Seth go. Um, all right, you see my Osiris window?
Yes.
Okay, so this patient's an 81 who presented um, with a stroke, some left cerebral hemisphere symptoms. So this is from the CT angio. And there's right here, you can see there's a segment of the middle cerebral artery right here that's out. And that's all I'm going to talk about since we do chest stuff. But what's kind of interesting is, so they had a suspicion. So she has a history of atrial fibrillation and had a Watchman device put in. So that's that left atrial appendage occluder that's placed percutaneously. So this was done to evaluate her Watchman device, and there it is. And you can see that the left atrial appendage is occluded and thrombosed. But the problem is there's this soft tissue on the atrial side of the main atrial side of the Watchman, and this is indeed all thrombus here. And looks like some of it may have adhered to the mitral valve a little bit. So the presumption is that this clot formed on the Watchman device and then embolized, causing the stroke. So part of the purpose of these Watchman devices is to prevent stroke, but in this case, it's the first time I've ever seen a thrombus on one. We don't see too many of these, but and they're usually anticoagulated, but I suspect this is one of the complications that can occur of any implanted body.
There was just a paper out. I can't remember where it was, radiology or maybe even a JAMA, not JAMA, Jack, talking about that this is not uncommon actually, and you can get even a very small amount of thrombus on the edge of the Watchman facing the LA, and depending on the specific morphology of the thrombus, some have a very high propensity to embolize. I'll try to find that article. It's very interesting because I know at UCSD we did pre-Watchman studies 2 or 3 a day, and they're shoving these in all the time. Um, So yeah, this is now a very recognized unfortunate complication.
Oh, okay. I don't encounter these typically in my practice because on the thoracic side, but yeah, this is kind of first one I've seen here. All right. The next case I have is, and Seth, you can maybe shed some more light on it. This is a 59-year-old who has multiple medical issues, including some substance use order, I think alcohol, and presented with what looked like a non-STEMI, troponins elevated, EKG changes, but had a clean cath. So they did a cardiac MR, and I'll start with this sequence here. And you can see on this vertical long axis, the apical portion of the ventricle is akinetic. And then I'll show it on a different plane here. You can see it's really not moving at all. And there's a little bit of outward motion, but not much. So in this case was shared with me by my colleague, Mark. This is what they're calling, and clinically and based on the MR, is Takotsubo cardiomyopathy or stress cardiomyopathy, but just a really nice example of it. I don't know what this precise stressor was, but like I said, she's got a lot of personal issues with substance abuse and things like that. But with, I guess, with a negative cath and all that, it all fits clinically. I don't know, is there anything else, Seth, that you would add or talk about?
There was no delayed enhancement, I'm guessing.
I don't believe so. Here it is.
My guess is presumably no. That's the T2s.
Oh, sorry, that's the T2. Sorry, I'll find it. They have so many darn sequences.
I know.
Was there any use of meth or something like that that might have caused some vasospasm? That
No, just alcohol from what I could gather.
Mhm.
Yeah, right there.
Yeah, it looks pretty good.
Yeah. No, I mean, it's presumably what it's going to be.
Does the delayed enhancement go with Takotsubo?
Usually you don't get any delayed enhancement with Takotsubo. You can get mild, but usually it's absent.
Yeah. Oh, I should point out that somehow the Osiris people are behind the ball this time. They haven't upgraded to work with the new Mac OS. Goodness, silly error. All right, now this is which case was this? Oh yeah, this is a cool case, David. You're going to like this one. So this patient has T cell acute lymphoblastic leukemia, and was relapsed, and so was on chemotherapy, got neutropenic, got fever, and so we did CT, of course. And there's a nodule, and you'll see there's several of these nodules with little nodules with halos. But then as we come down here, we get this big mass with this ground glass and center and all these little lines in it. So a classic bird's nest sign, which we have seen several times with Mucor. Now what's interesting, so they did a BAL, and of course the patient was on every antibiotic and everything, but the galactomannan was elevated, which apparently you don't see with Mucor, but you see with Aspergillus. And so they put the patient on a bunch of antifungals. This is presumably Mucor, but the thought is this is an Aspergillus co-infection, because all the stuff, the smaller nodules fit with aspergillosis, and this doesn't quite fit. So, and what's interesting is the follow-up, and I've not seen this happen before. So look what happens to the bird's nest. It kind of sloughed off and cavitated, which fits with what we kind of think it is an area of infarction. And you can see the smaller nodules now have these bigger halos around them. So it looks like it's two different infections, and that's what they're presumably treating the patient as, is Mucor and Aspergillus, because they, of course, at this point they're not going to isolate anything, and too sick to biopsy. But I have not encountered a cavitating bird's nest before, so that's the first one for me.
And
do you buy that? This is probably two different infections.
It could be, but I've seen Aspergillus cause a bird's nest too. I think the angioinvasion is the critical thing. But this lesion is so much bigger than the others that I think the notion that it's a separate infection is also very plausible.
Yeah.
But I will tell you that lavage is very poor at diagnosing mucor because
Yes.
I think because the organisms are deep in tissue, I think they just don't wash out.
Yeah. Yeah. It's just hard, and they're too fragile to biopsy, and they just
Right.
throw a bunch of antifungals at them. So anyway, it was kind of cool to see this. All right. That is all I have. I said Travis is away, and I haven't heard from Howard in a while. So,
I got cases, so I
oh
can
yeah,
share mine.
sorry, that's right. I switched. Sorry, it's been one of those
Yeah.
days.
So here we go. Oops, nope, don't close. Um, this is something that is just a little odd. So a young patient, never smoker, had a leg fracture. So she had a tibial or femoral fracture from a motor vehicle accident, and on an outside hospital, I guess she had I'm not sure, like an abdomen and pelvis CT. And at the basis of the abdomen and pelvis CT, they saw some cystic lung disease. So then they got a chest abdomen pelvis CT, and then they eventually sent her to us. Um, so I clicked on the wrong filter, so sharp. Sorry. So what you can see is just cystic change, pretty classic cysts, no real internal architecture within the cysts. What's interesting is she's a young female. They're upper lobe predominant, um, and her VEGF was elevated. But when you think of lymphangioliomyomatosis, it really is a lower lobe predominant process. It's either diffuse or lower lobe predominant. It's not, to have conspicuous sparing of the bases is quite atypical. So even though we thought it was LAM, given that I think the VEGF was borderline, it was like borderline elevated. She had no AMLs in the kidneys, um, no TS findings. And so based on that, she went for open lung biopsy. Would anyone just say, no, this is clearly going to be just a weird presentation of LAM? Have you guys seen upper lobe predominant LAM before?
Um, I've seen some emphysema look like this. I think
Yeah,
the lamb I've seen tends to seen more spare the apices rather than the
right.
bases.
And she
Yeah.
was a non-smoker, and there really wasn't any internal architecture in these
Hmm.
things to think emphysema. That's something I always am thinking a lot of this is.
Hmm.
Anyway, she underwent an open lung biopsy, and this was LAM. So this was a weird Lynch. That's one of the reasons Lynch kind of said she needs to be biopsied is that he's never seen an upper lobe predominant case of LAM ever, and we see, like most people, a fair amount of it. Um, but this was open biopsy, and this was all just typical LAM on biopsy. So just a kind of a weird look for a common or somewhat not common,
Yeah,
but not
cool.
common. This is just one of these things we see that is. Uh, and I know we've all seen a few cases, just kind of interesting. So unfortunately, I have to go back to. Oh, I think I have earlier studies in this, but anyways, um, patient with a connective tissue disease. I can't remember which connective tissue disease it was. Obviously, she's breathing a little bit on this older study from 2013. And we can see subpleural ground glass, conspicuous sparing, but this weird kind of cystic change. It's not all bronchiectasis. She's a never smoker, even though we have these areas here that kind of look like airspace enlargement with fibrosis. So that's 2013. I'll just fast forward to 2016. Show the prones. So kind of the cystic change, the ground glass is in some areas gotten better. The cystic change has kind of progressed, but still has subpleural sparing. And let me just show the most recent study. So, yeah,
And a dilated esophagus too.
yeah, a little. Yeah, 1 second. I'm in a meeting. Can I just? It's fine. Okay, bye. So these are the 0.2s, and yeah, esophagus is dilated. I think I'm not sure which disease, but again, never smoker, and we can see this really has become quite cystic with some of these areas, and like a lot of these other cases that we've shown of these weird cystic areas. Um, on expiration, they predominantly collapse or they get smaller on expiration. So even those areas here that were more airspace and largely with fibrosis up here kind of collapse on expiration. So, it's not really sure. It's clearly not UIP. I'm not sure if she had a biopsy or not. Actually, I don't remember if she did or not. But we've shown cases of this before where you have these people with this weird cystic stuff. Hers is presumably some weird form of progressive NSIP. Um, yeah, I just don't know what to say more than that. I don't, the fact that it collapses kind of points against. Honeycombing doesn't usually collapse down like this. Um, yeah, I don't know. I mean, I think we've all seen cases like this. It's just kind of interesting to surmise what exactly is going on in the parenchyma. Um, and I wish we had an open lung biopsy to tell. But anyways, this is just a nice case of something that's uncommon, quite pronounced here. So this is a young kid at this point where got some lymphadenopathy, clearly has quite pronounced large airways disease, bronchiectasis, plugging, all that good stuff, mosaicism from the small airway component, and almost looks CFE, but it's more lower lobe predominant, which is atypical. And I will show the most recent exam so you can see how this has progressed. So you can see that the trachea is quite thickened as well, somewhat circumferential thickening. And then you can see the irregularity in the thickening, kind of these areas of thickening calcification along the main stem bronchi and lobar bronchi. Kind of a look I often associate with amyloid, that thickening and calcification, but it's not an amyloid look in the lungs. So the lungs, you can see really severe lower lobe predominant bronchiectasis, something you kind of associate with the immunodeficiency of some form, but he had ulcerative colitis. So everything else was negative except UC. We know UC can cause severe airways disease, and we also know it can cause some degree of tracheal thickening, but this is just one of the more pronounced cases I've ever seen of UC associated airways disease and tracheal disease. Just a nice example of that.
Yeah, that was impressive.
Yeah, I thought it was going to be immunodeficiency from UC or something. He's like, no, everything has been tested in the world and it's just UC.
Wow.
And then lastly, Dave, this for you. Ooh, why is it not? Now why not going to load? I don't understand this stupid thing. Okay, I could show this part at least. So if I saw this as a chest radiologist, I would just call this an elevated right hemidiaphragm. And is there anything that points you to this not being an elevated right hemidiaphragm? Either of you guys would look at this and say this is something else besides an elevated right hemidiaphragm.
No.
The only thing on the frontal is the peak of the diaphragm's out lateral, so maybe
Yeah.
like a large pulmonic effusion.
Right.
Okay.
And that's probably what it is because you're showing it to a Seth.
Well, no, it's not. It's so let me show you. So then they got a sniff test, and I'm not even going to try. I don't even want to show this because I am so bad at sniff tests. I need to become better at them. But it was, and I don't even know how to load these, so I just think it's going to screw it up. Oh, that's nothing. Anyways, they had a sniff test. It was read as diaphragmatic paralysis. I cannot tell you if that is true or not. Um, that's not even going to load. Okay, well let me show you the CT. So young kid. I think this is a lung window, but let me get to the soft tissue window. Um, coronal anywhere? Coronal? No. Okay, so I will just show you this and show you a crappy coronal. Um, so here it is.
Ooh.
So
A
this turn,
giant fibrous tumor.
yeah,
Right.
it's just a massive fibrous tumor of the pleura.
Wow.
So this was taken out, and they did a repair of the diaphragm. Everything, it was just fibrous tumor of the pleura. But it's a big one. It's not the biggest I've seen, but it's big. But it was just like I would have never in a million years, because I read a
No,
follow
no way.
chest I read a follow up chest radiograph on the guy today, and I'm like, that's weird. He's got a thoracotomy. Oh, this is the first. Sorry, well, he doesn't hear because he got the tumor, but he had a thoracotomy changes, and I thought he might have had a lobectomy, but I'm like, no, his lobes are all there. So I figured maybe they did something in the mediastinum and they gave him phrenic nerve, and then I went back to the original. I was like, oh, never would have thought that in a million years. So just a nice case of a big fibrous tumor of the pleura.
Wow.
Yikes.
Okay.
Yeah, no, and it's just like, yeah, okay, sure.
I mean, it has not distorted the shape of the
No,
the bottom of the lung. So it's you know liquid can do that, but I'm surprised a solid thing like a solitary fibrous tumor has not distorted the shape of the bottom of the lung like that. So
yeah,
that's
well,
amazing.
I'm glad I'm not the only one because I was very, very surprised. When and the chest X-ray in this, you can look. I mean, it really just looks like a diaphragm. And the CT and the chest X-ray were basically 2 days apart. So it's just, anyways, good case, but I'll send those along. But that's what I
Yeah,
got.
that's great. Thanks. All right. Well, I think that's everyone. So awesome cases. A lot of diaphragms today. Um, all
And
right.
Yes.
Um,
pseudodiaphragms. Yeah.
yeah. I'm not available next week, so I'll talk to you guys the week after. I'll message Howard or Travis to see if they can run the show.
All right. Sounds good. Take care.
All right.
Thanks, everyone.
Bye,
Bye.
everybody.
All right. Bye.